Now we have to move on to the next session on radiotherapy in breast cancer. For this session, I would like to hand over to Dr. Prekshi for the coordination. And thank you once again, the chairpersons and the speakers. So please stay on with us, and over to you, Dr. Prekshi.
Thank you, ma'am. Good evening, everyone. So welcome you all in the third session. From 8 to 9, we'll have some interesting talks on radiation therapy in carcinoma breast, recent advances and the future directions. To chair the session, I now like to invite Dr. J.P. Agarwal, Sir is Professor and Head of the Department, Tata Memorial Hospital, Mumbai. Dr. A.K. Rathi, Sir is Director, Professor and Head of the Department, Radiation Oncology, Maulana Azad Medical College and Associated Hospitals. Dr. Manish Kerola, due to some reasons, he has not joined. So over to you, sir, for the next session.
Good evening, and it's quite interesting. Thank you, the organizer, for inviting me. Radiation therapy in the breast corner has been very, very essential, I would say, right from definitive to palliation. It improves the survival, the local regional control, and the quality of life. And all these three speakers are really seasoned speakers. And I now hand over my mic to Dr. Rathi to speak to you, and then we can hand over to our coordinator, who can call the very seasoned speakers to enlighten us on the future of radiotherapy.
Thank you, sir. In fact, in the COVID era, radiotherapy to breast is becoming more and more interesting. And the first talk itself is about fast forward. So we have to complete the treatment as soon as possible. Let's see. Dr. Tabassum, she's Associate Professor and Consultant of Radiation Oncology at Tata Memorial Center. Let's see how do we hypofractionate radiotherapy in breast. Dr. Tabassum, are you there?
Yes, good evening, everyone. And I thank the organizers for giving me this opportunity. So today I have been, I am supposed to talk about going fast forward in breast cancer radiotherapy, hypofractionated radiotherapy for breast cancer today and tomorrow. This is the slide which summarizes the history of hypofractionation in breast cancer spanning over 3 decades. HFRT for breast cancer was adopted way back in 1980s in resource-constrained centers of Northern England, Scotland, and Canada. And based on these initial experience, the innovative hypothesis and prospective randomized trials were undertaken in UK and Canada. The formal revisitation of the hypofractionated radiotherapy for breast cancer started in 1990s with the simultaneous advancements in the radiotherapy technology. These trials form the level 1 data to support routine use of hypofractionation for breast cancer radiotherapy. While majority of the trials of UK and Canada did accrue low-risk population, the trials like the RTOG, the Danish, Chinese, and the Indian HYPOT trials are accruing patients with high-risk population that were not adequately represented in the older trials. Hence, I would now take you through the various evidence with hypofractionation. So this is the slide that is summarizing the 4 important UK trials that have evaluated different hypofractionated regimens. In START A and the FAST trial, the treatment duration was the same, while it was reduced to 3 weeks in the START B trial and to 1 week in the Fast Forward trial. Except for the FAST trial, the primary endpoint for all the other 3 trials was locoregional control, and it was change in photographic appearance in the FAST trial. In the START trials, the HFRT arms were non-inferior compared to the standard arm for the primary endpoint. However, the high dose level arms of both FAST as well as the Fast Forward trials reported statistically significantly higher incidence of normal tissue effects compared to the standard arm. Similarly, the Danish HYPO trial, which had grade 2-3 in duration as the primary endpoint, also showed non-inferiority of the 3-week hypofractionated regimen. The mature results of the Ontario trial reported no difference in the local control rate as well as the normal tissue effects. However, despite the level 1 evidence and the numerous guidelines strongly recommending a moderately hypofractionated radiotherapy, the adoption has been variable across different countries. It is to the tune of 70 to 80% in the countries that have conducted these trials, and ranging from 28% in US to 45% in Australia. In India also, the uptake of HFRT has increased steadily, and various Indian academic centers have already reported the initial experience and safety of moderately hypofractionated radiotherapy in adjuvant breast cancer. Now coming to talking about in detail the ultra hypofractionated regimens, that is the FAST and the fast forward. The FAST trial these two trials tested the limits of extreme hypofractionation. The FAST trial accrued 915 patients during 2004 to 7. This trial was carried out basically in elderly women who had undergone BCS and had smaller tumors with negative margins. The actual trial characteristics, patient characteristics, were that of an extremely low-risk population comprising of women older than 60 years, T1 tumors, low-grade and predominantly hormone-positive tumors. In this trial, patients were randomized to standard arm of 50 gray in 25 fractions and 2 test arms, 30 gray in 5 fractions and 28.5 gray in 5 fractions. The duration of treatment was 5 weeks in all the 3 arms. The patients were assessed clinically up to 10 years, and photographic assessment was done at 2 and 5 years. The primary endpoint was 2-year change in the photographic breast appearance with several of the secondary endpoints. In this trial, standard bitangents were used and 3D dose compensation methods were employed to achieve a good dose homogeneity between 95 to 107%. Large majority of women underwent forward planned IMRT, which is essentially MLC-based FIF technique. The methods of dose prescription and reporting criteria were also standardized, and a high compliance rate was observed with the RT planning across different centers. So the 10-year update was published last year, and as you can notice from the graph, there was clinical as well as statistically significant difference in the percentage of overall change in the breast appearance for the 30 gray arm compared to the standard arm. The 28.5 gray arm was milder. The proportion of patients developing marked changes was very few. It was 2% in the standard arm and the 28.5 gray arm, while it was 4% in the 30 gray arm. So based on this, alpha beta estimates for photographic change were calculated, and it was found to be 2.4 gray. When you look at the Kaplan-Meier estimates of the toxicity of the late effects, basically moderate to marked breast shrinkage, the overall incidence was higher in the 30 gray arm. And when you look at the incidence of breast induration, you find the similar findings that the higher dose level had a higher was having higher toxicity, whereas the 28.5 gray arm had a little difference in the induration, but the differences were not statistically significant. Now let us discuss the fast forward trial, which was published last year amid the pandemic. As compared to the FAST trial, the eligibility criteria was supposed to be broader, but again, the actual patient demographics reveal a low-risk population essentially. Notably, only 15% women were younger than 50, 30% had node positive, while boost was given in only 24% of patients. This was a large randomized trial of 4,000 women between 2011 to 2014, and the 14-15 was the standard arm, the 2 test arms in which 5 daily fractions were given. One was for 27 gray and the other arm was 26 gray. The primary endpoint was local control. So the initial report on the acute toxicity was published, and in this paper they did the analysis of acute toxicity by two methods. One with the RTOG, in which you can see the rates of grade 3 toxicity were higher, and this was because the pitting edema is included in the RTOG scoring, which is not the case in case of CTCA. So as the main purpose was to report moist desquamation following radiotherapy. So the CTCA criteria was used, and as you can see, there was no grade 3 toxicity in the standard arm and the 26 and 5 gray arm, whereas 2.4% incidence of moist desquamation was seen in the higher dose level arm. Overall, both the schedules were well tolerated, and the acute toxicity was considered acceptable. Now, coming to the primary endpoint, which was the local control. As you can see, the local control it was excellent. At 10 years, it was around 2.1% in the standard arm, and both the hypofractionated arm were non-inferior with respect to the primary endpoint. This is the slide which is reporting the physician-based reporting of late toxicity. The green color values represent the toxicity in the 27 in 5 arm, and the blue the values in blue report the toxicity in the 26 in 5 gray arm. So as you can see, most of the toxicities except the non-tumor bed breast induration were comparable in the standard arm and the test arm 1, which is the 26 gray in 5 fractions. However, if you see at the toxicities in the test arm 2, all the toxicities had higher incidence, and this difference was also statistically significant. The Kaplan-Meier estimates also showed a similar trend. However, when you talk about the patient-reported outcomes, you can see that the increased induration, which was assessed by physician, was perceived as hardness or firmness, and this was significant even for the 26 gray arm, while for the 27 gray arm, most of the patient-reported outcomes were also worse as compared to the standard arm. This is the slide which is summarizing the alpha beta values which have been derived from all the trials from UK. And it is important to understand this, that the local control alpha beta values have been consistently reported in the range of 3.5 to 4 gray across all the trials. The individual toxicities and the alpha by beta ratios vary, and hence this is an important thing to consider while designing future radiotherapy trials with the consideration of the particular endpoint that is being considered for the trial. I would like to discuss this important paper which has been recently published, and in this paper authors have tried to assess the time trend of toxicities of the ultra hypofractionated arm compared to the 14-15 gray arm. So as you can see, with respect to the shrinkage and the induration, the curves are getting separated, which means that with the mature follow-up, the incidence of induration and shrinkage is likely to increase. Hence, it is a word of caution. And moreover, while extrapolating these results to our routine patients, it is important because we see more advanced tumors, as well as we offer a boost to the tumor bed to majority of the patients. And what this effect will have, giving tumor bed boost to majority of the patients, what this effect will be having on the late normal tissue effects is yet to be seen, because we don't have the results from long term from the mature data. So practically, if you speak about breast cancer hypofractionation, it cannot be without simultaneous integrated boost. So I would like to show here the evidence for it, and there have been numerous trials. Few of them have completed and few of them are ongoing, which have addressed this issue. And the main advantage would be offering concurrent boost, because that will be the only thing that will truly reduce the overall treatment time. Now, coming to the IMRT MC2 trial, this was done in conventionally fractionated radiotherapy. Here, 16 gray in 8 fractions was sequential boost was compared to 64.4 gray in 28 fractions for with SIB. So as you can see, the 2-year outcomes for the local control as well as the breast retraction were not different in the 2 arms. So taking forward the observations from the START A and the B trials, the UK investigators explored the hypothesis of both mild de-escalation of the whole breast dose from 46 to 40 gray EQD2 in both the arms, and tumor bed de-escalation in test arm 1 from 62 to 60 gray. In the test arm 2, they did explore dose escalation to the tumor bed from 62 gray EQD2 to 68 gray EQD2. And in this trial, all patients underwent SIB using IMRT. So in contrast to the previous STAR trials, this trial included a relatively high-risk population, because of which the name of the trial is IMPORT High trial. 50% of the women were younger, had high-grade tumors, 30% were node positive, and 40% had adverse molecular subtypes. So if you observe the bar chart as well as the Kaplan-Meier curves, you can see that the test arm 2 had higher incidence of breast induration documented by physician, and which was statistically significant both when compared to the standard arm as well as when compared to the test arm 1. On the other hand, in the test arm 1, the expected reduction in the incidence of induration compared to the standard arm was not observed. And similar observation was seen for the patient-reported outcomes at 3 years. So there was no significant difference in the two test arms. Coming to the RTOG trial, which is an ongoing trial, and here 2,100 women are randomized to standard fractionation and hypofractionation, and the policy of boost in the hypofractionated arm, they have allowed various radiotherapy regimens in which sequential or concurrent or simultaneous integrated boost have been given. Is allowed, and here the high-risk population is defined by age less than 50 years, positive nodes, close margins, high-grade presence of LV, ERPR or a negative status, or oncotype DS score having more than 25. Here also again the local control is the primary endpoint. So as I have already mentioned, it has allowed essentially 7 types of techniques to explore whether boost can be given concurrently or simultaneously. If the boost is delivered separately as a separate plan from the breast plan, it is called concurrent, but if it is delivered in a single plan, it is called simultaneous integrated boost. And as a rigorous QA process was followed, and because it is a multi-institutional trial, and hence various during the QA process, they have studied inconsistencies in the plans and failure patterns, and hence this credentialing procedure was followed before the trial was initiated. Now, coming to the Danish Hypo 2 trial, this is also testing a SIB approach, and here they are offering SIB in 2 dose levels, both for the standard arm as well as for the hypofractionated arm, and the sample size is 2,000, and it is expected to complete its accrual into 2022. This is the Chinese trial, which has already been published at a median follow-up of 53 months. And this is essentially different from the trials which have been discussed earlier, because this has been done only in post-mastectomy patients. And this gives us reassuring results that the hypofractionated radiotherapy is non-inferior to standard 5 weeks radiation. However, in this trial, a little higher dose with EQD2 equal to 50 gray was used, and instead of 2.7 gray per fraction, which is the start fractionation, 2.9 gray per fraction was used for mastectomy in this trial. And briefly, this is the trial which is being conducted by Tata Medical Center, Kolkata. And here again, the main objective is to study the safety of the 1 week adjuvant radiotherapy schedule. And again, this is a non-inferiority trial with 5-year loco-regional control as the primary endpoint. And this is also been conducted at various academic centers across the country. Hence, to conclude, I would say that is fast forward the new standard of care. I would say still it cannot be the current standard of care. Moderately hypofractionated radiotherapy remains the current standard of care, and there are reasons for this, because tumor bed boost was given only in 25% of women, and synchronous boost regimens were avoided to allow a pure assessment of whole breast hypofractionation, without having to consider the partial volume effects of the different dose levels. Simultaneous integrated boost, which is being explored in the RTOG, HYPOD, and the HYPO2 trial are ongoing, and we await these results. And as mentioned, I described the paper from Krug et al. The temporal trends in the normal tissue effects are expected to be different with uniform prescription of boost and synchronous administration. Hence, I would say that breast hypofractionation does give a high quality level 1 evidence. It is convenient for the patients as well as provider. It is cost effective, resource sparing, and it has all the potential to increase the access to radiotherapy. So currently, moderately hypofractionation is the standard of care, and ultra hypofractionated regimens will continue to evolve in the coming years, and data from the randomized trials is eagerly awaited. Thank you.
Thank you, Dr. Tabassum. Dr. Prekshi, do we take any questions?
Sir, we can take it at the end of the session. So
Okay, okay. So, Dr. JP.
So please, can we ask our next speaker, Dr. D.N. Sharma? Hello.
Sir, actually, Dr. D.N. Sharma is not well. So Dr. Dinesh Singh will be taking the next session instead of him.
My friend Dinesh,
Hello,
it's a pleasure to have him on this. You know, he's an immediate, he can take on anything. Believe me that. That is how versatile Dinesh is.
Thank you so much, JP.
Welcome, Dinesh, for this exciting talk of yours on APBI.
Thank you, Dr. JP, for these encouraging words. And I would like to say at the onset that the talk was to be taken by Dr. DN, but because he is not well, so I took it up at the last time. I'm trying to share my screen. Is it visible now?
Yes, dear. Yes.
Okay, thank you. So I will be taking on from where Dr. Tabassum has left, that the theme of this conference being the making it shrinking and shrinking in so that the patient gets the same benefit, and with minimizing the side effects which are associated with the treatment. I'll be talking about expanding role of APBI in breast cancer. Well, as we all know, the aim of radiation therapy is to improve loco-regional control, to improve overall survival, and simultaneously to keep radiation-induced morbidity at the lowest. So, the concept of accelerated partial breast irradiation, in this, the target volume irradiated is only the post-lumpectomy tumor bed with a 1 to 2 centimeters margin all around. This is an accelerated dose delivery. The dose is delivered in a shorter interval than the standard 4 to 6 weeks. Treatment is delivered twice a day with treatments separated by 6 hours for 10 treatments usually delivered over 5 treatment days. Well, most breast cancer recurrences, they occur in the index quadrant, and hence a higher dose of radiation is warranted there, and it can be given in the APBI because we are irradiating a small volume of the breast. Then and many patients cannot come for a prolonged 4 to 6 weeks adjuvant radiation for logistic reasons, that it reduces the overall treatment periods considerably, our APBI. There is increased patient convenience, which also results in increased acceptance of radiation treatment after breast conservation surgery. Well, various trials have been done to study the non-inferiority of APBI as compared with the standard of radiotherapy which was done. And they have been randomized trials for APBI. And what they have done, they have studied this with the whole breast irradiation, 50 grain 25 fraction in most of the trials, along with the hypofractionated, like the APBI things. Some studies, they have used the external radiation, and there are some studies which have used the brachytherapy, and other trials were used like IACT and target trials. We will be discussing about them. And as per the ASTRO, the patient's criteria have been laid down, that which patients are suitable, borderline suitable, and not suitable for APBI. So as regarding the suitable patients for APBI, if all criteria are present, age more than 50 years, BRCA mutation not present, tumor size less than or equal to 2 centimeters, margins negative by at least 2 millimeters, any grade, no LVSI, ER status positive, should be unicentric, and histopathology invasive ductal or other favorable subtypes. Pure DCIS is allowed if screen detected, and associated LCIS was allowed. It should be node negative patients, either sentinel biopsies or ALND, and these patients should not have received any kind of new adjuvant therapy. Then there was a group of patients which were put into the cautionary list. Age 40 to 49 can be taken up for APBI if all other criteria are met, and in age 50 or higher, if the patient has at least one of the pathological factors which does not have any unsuitable factors, can be taken up. Tumor size was increased till 3 centimeters. Margins, closed margins up to 2 millimeters. LVSI limited or focal, ER negative was also included. Multifocality, clinically unifocal with tumor size 2.1 to 3 centimeters. Invasive lobular was also permitted, and the tumor size should be definitely less than 3 centimeters. So if any of these factors is present along with other favorable factors, then patients more than 50 can be taken up for APBI. However, some patients are absolutely no when we are considering for APBI. Notably, if the age is less than 40 years, if BRCA mutation is present, if size is more than 3 centimeters, if margins are positive, extensive LVSI, if it is multicentric, or if microscopically multifocal more than 3 centimeters in total size, or clinically multifocal, pure DCIS more than 3 centimeters, EIC more than 3 centimeters, if any nodes are positive, and if nodal surgery has not been done, and if neoadjuvant therapy has been used, then these patients should not be taken up for APBI. Well, there are various modalities to deliver APBI has been used. Most common is external radiation using 3D conformal or IMRT. Another is HDR, interstitial brachytherapy. Then intracavitary brachytherapy using mammocyte, and intraoperative electrons like in the ILIAD trial, or orthovoltage X-rays in the target. The benefits of APBI is that we can deliver larger dose to a smaller area, and also there is the normal tissue exposure to radiation gets reduced. So, and the treatment gets completed in 1 week instead of 4 to 6 weeks. But there are some limitations associated with this, that some techniques, they require additional surgical procedure. It requires twice daily treatment. I would like to mention here that one of my patients, an elderly lady, she was perfectly suitable for APBI. And when I discussed the treatment of APBI with that patient, her relatives, they refused to accept APBI simply because the patient will have to come twice a day, and the caregivers, they could manage coming only once a day because they were working. So this is one of the drawback with this. It's a newer modality with far fewer patients treated and much shorter follow-up is available. So much data will be available as we move on in time. The external beam radiation is attractive to both physicians and patients because it is non-invasive. It delivers a homogeneous dose with decreased procedural trauma to the breast. It offers a potential reduction in radiation dose to the normal breast and also to the lung and the heart. So which is very advantageous to these patients. Then interstitial brachytherapy is used in small targets, usually up to 2 centimeters. The catheters are usually double, these channels are used, and they have to be positioned at 1 to 1.5 centimeters interval. Total number and planes are dependent on the size, extent, and shape of the target. Post BCS, either we put these catheters intraoperatively, or it is done 2 to 3 weeks after the surgery in the lumpectomy site. Then after simulation with CT simulation, and the patients are treated, dose delivered is 34 gray in 10 fractions, 3.4 gray per fraction, 2 fractions per day, and given over 5 days. Mammocyte is another technique for giving APBI. It is a catheter with expandable balloon at the end. The balloon is filled with saline mixed with contrast for verifying positioning. It expands to fill the lumpectomy cavity, and radiation dose is prescribed to 1 centimeter beyond the balloon surface. It is also 34 gray in 10 fractions over 5 to 6 days. The advantage, it's a simple, minimally invasive technique. It offers acceptable cosmetic results and induces mild side effects. The disadvantages are the balloon must conform to cavity shape without any air gaps. And the ideal is to have 7 millimeters between balloon and the skin to decrease the risk of erythema. And it is very dependent on the surgical placement. This balloon catheter is connected to the HDR equipment to deliver the radiation dose. The patient comes twice a day in the radiation department and the catheter remains in place for the duration of the treatment. Another technique is intraoperative radiation therapy for partial breast irradiation. In target trial, they compared whole breast radiation to intraoperative radiation. They delivered a single dose of 20 gray. Intrabeam was the equipment used to give photons. 50 kV X-rays were delivered. Intraoperative electrons can also be used with mobile linear accelerators and cylindrical applicators for electron beam collimation. This is another technique where available. I don't think in India we have it available. This is the target in which the X-ray source is placed into the cavity. The various sizes of these applicators are available, and as per the size of the cavity, it can be decided that which applicator is to be used. After surgery, it is done into the OR, and after lumpectomy, the probe is placed inside the cavity, and then it is exposed with the 50 kV X-rays. And a single dose is delivered, and after that, the applicator is removed. The surgical procedure is completed and the patient is done with the radiation treatment. This is an Elliott in which intraoperative electrons are used. This is an intraoperative electron apparatus in which after the lumpectomy, the protective coverings are placed at the bottom, and then after that the patient is delivered with the electrons. Well, these are the summary of the different techniques. We are having interstitial brachytherapy. We are having intracavitary brachytherapy, intraoperative radiation, and the 3D conformal radiation or IMRT. At my institute, we are mostly going with the external radiation because of the ease of advantages. However, few patients, depending upon the choice of the institution, they can take up any other option which is available. So APBI, it reduces the volume of breast getting radiotherapy. And it also reduces dose to the lungs and to the heart. It reduces dose to the opposite breast, and it decreases treatment time to 1 week. It reduces expenditure during radiation because the patient has to manage logistics for 1 week as compared to 3 to 4 weeks when the patient is undergoing a regular course of radiotherapy. So all suitable patients must be offered the option of APBI. Well, I would like to mention here that at our institute, our surgical and medical oncologists are considering this regularly option, and all the other institutions, they should also adopt the policy that after the surgery or before the surgery, it can be discussed in the multidisciplinary tumor board that whether the patient is suitable for APBI or not. And in those cases, APBI can be completed after surgery and before the chemotherapy is started. But once the patient gets completed with the chemotherapy and then the patient comes for APBI, then also APBI can be done, but it's a matter of adoption by the institution. Thank you. Thank you, everyone.
Thanks, Dinesh, for coming at the last minute. I think we are going to take questions at the last. With the permission of Dr. Rathi, do I call the next speaker, please?
Sir, please go ahead. Go ahead. Thank you so much.
Sapna has been a great friend, very insightful lady, and she puts her argument with a very strong evidence-based strategies. And I really welcome her on this occasion to present on the adjuvant breast radiation using protons. Sapna, stage is yours.
Thank you so much, Dr. JP. Those were very kind words. Thank you so much. I'll just share my screen. So I'd like to thank Dr. Prekshi, Dr. Vaishali, and Dr. Arun Goel for having given me this opportunity. And I'm very happy to share some of the initial data that has come in. So this is about adjuvant therapy in breast cancer using protons. And of course, we do know this is a gathering of breast oncologists, and I don't think I need to really labor the point that radiation does have a role, not just in preventing locoregional recurrence, but this locoregional recurrence translates into a survival benefit. And in patients, for example, with 1 to 3 lymph nodes positive, the survival advantage is as much as 8% at 15 years. We also know that even in limited, early stage elderly patients, it is not advisable to omit radiation. In this background, we also have to note the fact that with the advances that have taken place in the treatment of breast cancer, we expect women to survive for long. And from our own country, this excellent review of more than 2,000 patients reported from Tata Memorial tells us that even patients with locally advanced breast cancers, as many as 70% are going to have disease-free survival. So we expect, of course, the overall survival is going to be higher at 5 years post-treatment. In this context, then it becomes relevant to pay attention to survivorship issues. There are many survivorship issues that have now gained our attention, whether it be the neurological toxicity of radiation, of chemotherapy in the form of a chemobrain, or oncofertility issues. There is also attention being given to the fact that a lot of or some of the treatment that is being given for breast cancer may be associated with a higher risk of cardiac toxicity. So when we look at radiation, of course, we do understand that over the years, with improvement in techniques, there has been an decrease in the risk of developing heart problem. But the issue of the risk of having a heart problem remains relevant. And when I talk about that, I mean, when we look at the literature, we find, for example, from this study from UPenn, we find that even though there is no difference, significant difference between death from any cause between left or right-sided breast cancer patients, there is a higher proportion of patients of left-sided breast cancer who will have coronary artery disease or who will have myocardial infarction. Similarly, we find that patients who have left-sided breast cancer are more likely to have chest pain or coronary artery disease or myocardial infarction vis-a-vis those with right-sided breast cancer. And also, when we look at patients who have undergone coronary angios, we find that patients who have been irradiated are likely to have a different pattern of abnormalities on angiograms. So, for example, if the average woman is likely to, the risk of having coronary stenosis is only about 46% in the LAD, the others being right coronary artery or left circumflex artery. But in patients who have undergone irradiation, as many as 85% of patients will have abnormalities in the left anterior descending, which we know is close to the left-sided target when we are treating the heart or we are treating the chest wall. And as many as in 62% of patients, the LAD is the sole site of stenosis. The radiation-related heart disease can involve all the, the tissues of the heart, and therefore there can be pericarditis, there can be myocarditis, that can be intimal narrowing. And as we see across the board, not just in the heart, but various situations, this is primarily because of fibrosis that happens because of hypoxia and the subsequent issues that arise because of that fibrosis. So there can be macrovascular injury, which may lead to reduced flow to a portion of the myocardium. There can be microvascular injury, which reduces the collateral flow and vascular reserve, and this can result in myocardial ischemia. This is, of course, a very famous study from Darby et al. And of course, we all know 7.4% per gray, etc., etc. But what I want to specify here is that there are a few things that we have to note here. One is that there was a doubling of risk associated with diabetes mellitus, COPD, chronic use of NSAIDs, smoking, and high BMI. Also, patients who had previous ischemic heart disease had a 6.6 times a higher risk of developing a heart problem. When we are talking about this risk of having a heart problem, we also have to note that the definition was actually very strict in that this was only myocardial infarction, coronary revascularization, or death resulting from ischemic heart disease. So we are not discussing the anginas, the pericardial effusions, etc., etc. At this point of time, I've not added those slides for basically focusing on the proton aspect, but I would like to mention that there are a number of studies that tell us, for example, SPECT studies that tell us that there is a reduction in the vascularity in the apex following radiation in a significant number of patients. Similarly, there is an increased risk of developing heart failure in women who have received more than 4 gray, or the proportion of women having heart failure is higher in women who have a mean cardiac dose of more than 4 gray. Now, placing this in context of our situation, of the Indian situation, we do know that we have wide variations of the population, but we also have a significant obese population, And amongst this significant obese population, we can see that in the recent studies, as compared to the ones in 1992, in the more recent studies, we see that as many of 50% of between 30 to 50% of patients who are obese may also have coexisting diabetes. So yes, there is a group of our patients who are at a slightly increased risk of having a doubling of the cardiac risk. Excuse me. Darby's paper did not have many patients who had received adriamycin. A very small proportion of patients had received adriamycin and none had received trastuzumab. We do know from various retrospective studies, for example, from a Korean study, that the risk of having a heart problem, the hazard ratio is about 1.2 for patients who have undergone treatment with adriamycin. So we do know that a lot of these medicines, the systemic therapies that patients receive are associated with the risk of having a heart issue, and those are diverse. So even letrozole is, after all, associated with the risk of doubling of cardiac events. And besides adriamycin and trastuzumab, docetaxel, cyclophosphamide, and 5-FU are also associated with cardiotoxicity. In this background, we have to see also the emergence of coronary artery and ventricular segments as organs at risk. So this is a study from Taylor et al., where they have looked at patients who had already undergone ventricular injury, patients who had been treated for breast cancer and had undergone ventricular injury, and then noted that patients who had, abnormalities in the septal region or the apical region were preponderantly likely to be patients who had left-sided breast cancer. Similarly, the risk of developing coronary stenosis was higher according to the LAD position. Stenosis in the LAD, the risk was higher in patients who had left-sided breast cancer. So of course we know that the standard method of reducing the dose to the heart is deep inspiratory breath hold, which exploits the distance between the heart and the cardiac substructures and results in the decrease in the volume of the heart. And this is some of our own data of 50 patients where we did a dosimetric analysis and then treated patients using deep inspiratory breath hold. So I am placing this only to place this in context with proton therapy, but we do know that with deep inspiratory breath hold, there can be a reduction varying from about 40% to 70% in various parameters. So this is about a nearly 40% reduction in the mean heart dose and almost a 75% reduction in the left ventricular V25. So we do know that with deep inspiratory breath hold, we can reduce the dose, but now we do have something which is, can take it forward. And why we are discussing it today is because this technology is now available in the country. This is the Apollo Proton Cancer Center. And of course, there are in the West, there are a number of centers. In Japan, they have always been proponents of proton therapy, but in this part of the world, this is the first proton center. And now to place in perspective what proton does, if this is a tumor, a photon for the non-radiation oncologists in the audience, a photon will deliver radiation as it goes along. If we were using only a single beam to treat, then radiation would be delivered distal to the tumor. Also, with proton therapy, there is no dose distal to the tumor. All the dose, because it is a particle carrying a positive charge, all the dose is deposited at a pre-specified point called the Bragg peak, named after the scientist who described this, and then a smaller energy to cover the tumor and another smaller energy to cover the tumor till we have the spread out Bragg peak, which then allows us to dose escalate because we are being able to spare the normal tissues better, or spare normal tissues, or exploit radiobiology, or do all that. So there have been 3 generations of proton therapy. The initial was the passive scattering, then the universal scanning, and the latest technique is called pencil beam scanning, where spots of proton are placed layer by layer so as to cover the tumor in a very conformal manner. And most modern installations will have pencil beam scanning, and so is the case at the Proton Center in Chennai. And to get straight to the point, this is the first patient that we had treated, and so I would like to highlight a proton plan versus a tomotherapy plan, where we see the breast area, what we wish to cover with the 95% of our prescription. The breast is in yellow, and actually everything else which is outside of that is unnecessary radiation. And then when we compare the dose fall off into the heart and the lungs in the proton versus photon, I think it becomes quite obvious what the advantages of proton are. And what this translates into in terms of the mean dose to the left anterior descending, for example, the mean dose or the 0.02 cc, as I already mentioned, the dose to the various segments of the left anterior descending is correlated with the risk of having coronary stenosis. We don't understand the constraints very well. We don't understand the risk factors very well, but we do know that there is some correlation with the dose being received by the LAD and the risk of having a heart problem. And there is a recent study that has looked at the dose being received by the calcified plaque in the LAD and then correlating it with the risk of having a heart problem. Now, because in protons, we are delivering the dose en face, which means facing the breast, it becomes very clear that what we are exploiting is that it will not move distal to the rib cage. So the concept that we use is called robustness, wherein instead of a planning target volume, we see whether the plan will still maintain what we want it to do, even if we shift the patient, or if the range of the proton is a little inaccurate. We use surface guidance to make sure that the positioning is correct. And the aim of this is to reduce the cardiac dose to 1 gray and also to reduce the risk of second cancers. So when we look at this study, when we look at IMRT versus IMRT in breath hold versus IMPT, intensity modulated proton therapy, we see that there is a drastic difference where this is almost touching the x-axis, where the cardiac doses are really very, very minimal. So this is some of the patients whom we have treated. The green is the 1000 centigrade, so which means that is about less than 25% of the dose, and we can see that it is sparing the heart very substantially. And we are also identifying the coronary substructures, the left anterior descending or the right coronary artery, the various substructures, the various walls of the left ventricle, and we can see the sparing is really very gratifying, whether it be chest wall, whether it be right or left. One of these patients is the second patient is actually a 29-year-old. So where we are actually gaining the advantage of also reducing the integral dose and therefore reducing the risk of having second cancer. So this is the first 5 patients. The mean dose to the heart in left-sided breast cancer patients is 0.9 gray, and the mean heart dose in right-sided breast cancer patients is 0.56. The mean LAD dose, the mean right coronary artery dose is of course very, very small. I'd also like you to pay attention to the left ventricular dose, and I'll come to it slightly later as to why I am discussing that. And also an important point to note is that our usual mean dose to the lung is in the range of about 12 gray, and here we are talking about a mean dose to the ipsilateral lung in the range of about 7.3. Now I'm placing it in context of the DIBH. So from 5.2, those were only left-sided breast cancer patients, so 0.9. From V5 gray to 3 point, from 35.2 to 3.1. And then from the LV mean dose, we have come down from 5.9 to 1.79 and so on. So basically there is this should be 43.2 to 43.2 to 1.79. So what is the relevance of this? So how is this going to translate into a benefit for our patients? And so this is a model that has been proposed by Van den Bogart in the JCO in 2017, where he's looked at the risk of developing. So for example, for a patient who's had ischemic heart disease, the same dose that we have given with DIBH would result in about a 12% excess risk of having an acute coronary event, while the same thing when delivered in proton is actually negligible. So that is the advantage when we are talking about using proton in the adjuvant therapy of breast cancer. So this is our first patient, and this is just a slightly more detailed. So this is the hypofractionated SIB boost, that Tabassum spoke about. This has been our protocol, my protocol that we had been using at Apollo Proton for all these years, at Indraprastha Apollo. So we didn't change. There was, that whole dictum of not changing too many things. So we just carried forward the same photon system into proton, so that, there were no surprises. And so whole breast boost, SIB boost, equivalent coverage, the nodal target volumes. And here when we start seeing, the difference of the LAD dose with proton versus LAD dose with, this is a comparison of proton with tomotherapy. The LAD dose with tomotherapy is definitely higher than with proton therapy. This is the, on completion, the cosmesis is satisfactory. And this, I think I've already mentioned. So for all parameters, as we can see, it almost becomes 1/10 or 1/5 in that range of what is possible with photon techniques. Also applies for contralateral breast, also applies for ipsilateral lung. And interestingly, I think we are doing this right versus left comparison so often. However, we must recognize the fact that, especially in patients in whom we are treating the internal mammary lymph nodes, we are treating the right coronary artery. And that actually, we can see that even in Taylor's paper, when she's looking at, left versus right, you can see that there is a shift towards the right coronary artery events in patients who have received right-sided breast irradiation. So perhaps we should be looking at deep inspiratory breath hold techniques for right-sided breast cancer patients also. And also, this is open for right-sided breast cancer patients, proton therapy. So this is the phase 2 data that has been published by Jimenez et al. From the Mass General Hospital, a local regional failure rate of 7 years of 1.5%, and overall survival of 91% in patients with, patients, 70 patients. The mean hard dose in this situation was less than 1 gray. There are a number of clinical studies, because this is a planning study, but there are also a number of clinical studies. Again, we can see here, this is 3D CRT, this is IMRT, and then this is proton therapy. So this is actually a fairly repetitive, except to say that there are now a number of dosimetric studies. So this is proton therapy 1.2 mean hard dose versus 4 with 3D CRT, 6.8 with 3D CRT with internal mammary lymph node, and so on with helical tomotherapy as well as VMAT comparisons. The black bar that you see is the mean LAD dose. That too is significantly less in proton therapy. And then there are a number of clinical studies too. I think the slides have got jumbled. So then we also look at the advantage of this is then in models, we come to know that there is a significant reduction in the risk of second cancers, especially when we are doing nodal irradiation, simply because of the reduction in integral dose. So the risk of developing a second cancer becomes less after proton therapy, and that is actually self-explanatory. When we see this, the integral dose that's going into the lung or the integral dose that is going to the opposite breast is smaller with patients receiving proton therapy. Bilateral breast disease, of course, again, the greens, these are the greens, and these are all the OARs. I'm sorry, it's very small. This is the lung, this is the LAD. So the green is the is the proton therapy. Again, much less in patients who are receiving proton therapy. So these are the clinical studies. At the point of being repetitive, what I'll say is that they all say that the mean dose to the heart is in the range of about 1 gray. The V5 is very small, and the total lung dose is also very small. Same. Now, interestingly, the last time I presented this, somebody asked me, what about APBI and proton therapy? So there is somebody who has explored APBI with proton therapy. I'm sorry, I seem to have missed putting this. This paper came from Mayo Clinic in Rochester, and it has only been published in the Red Journal in February 2021, 100 patients. The heart dose is 2 centigrade. So routine APBI mean heart doses are in the range of about 1 gray, 1 to 2 gray. And this is 2 centigrade. This is the cosmesis and the patient satisfaction. So the orange bar is the cosmesis at 1 year, 2 years, 3 years. About more than 90% of patients are satisfied. And then total satisfaction rate, again, we see it's quite high. And at 2 years, 0 patients have grade 2 toxicity. At 3 years, 0 patients have grade 2 toxicity. In the earlier times, there are hyperpigmentation and dermatitis are some of the issues that patients have noted and complained of. So this is the RADCOM trial, which is looking at randomizing patients between proton and photon therapy. It's a pragmatic trial, which has not assigned any. So basically, the system of the department is followed, both in terms of dosage and they are comparing the effectiveness of proton versus photon in reducing major cardiovascular events, which have been defined as coronary artery disease, death, myocardial infarction, revascularization, or hospitalization for major cardiovascular event, heart failure, valvular disease, arrhythmia, or unstable angina. So their spectrum is a little broader than what Sarah Darby's group looked at. So we have instituted the hypofractionated registry, HyproB registry, where we are looking at delivering a hypofractionated treatment schedule, 40 gray in 15 fractions, with a simultaneous infield boost of 48 gray. This is the sort of prescription that we have given, and this is what we have achieved. So actually the LVV doses and all, our V5 is in the range of about 0.68. So that is actually, this was earlier in the DIBH was in the range of about 40. So that's what has been possible to be achieved. This is the dose distribution of the patient. And the blue dose color wash is 1400 centigrade. And so that is what is possible. And so in my conclusion slide, I'd like to say that proton therapy for breast cancer fulfills the principles of ALARA. However, I think the basic discussion, once you see these dose distributions, what would be the reason why we would not offer this to patients? I think it is because costs. The cost requires us to identify patients judiciously. And in that context, we have to see which are the patients in whom we may look at it. Young women, diabetics, smokers, COPD, analgesic, these are the Sarah Darby's identified group of patients, obese, hypertensive, ischemic heart disease, and also bilateral breast cancer. Had cost not been constrained, I'm very sure that all the radiation oncologists in the audience would agree with me that this, you can't beat this at present, at least we can't beat this kind of a dose distribution. But yes, we have to be cognizant of cost, and therefore it does become limited to, a segment of the population that can afford this kind of a treatment. So this is the group, and this is the machine. And so the central rationale for proton therapy, as in all sites, remains its superior spatial distribution in the patient. And the relative advantage of proton therapy is sparing normal tissues, which has never been more apparent or important. As I said, in India too, we know that anywhere between 70 to 85% of our patients, breast cancer patients, are going to be alive at 5 years, and therefore it warrants consideration. Thank you.
Thank you, Sapna. I think we are running a bit late. I want to thank all speakers and organizers, and I hand over to she, if Dr. Rati permits.
Yeah, sir, please, please. Thank you so much for being there.
Dr. Chaudhary, it's all yours if there are any questions. Thank you.
Thank you, sir. The sessions were wonderful, really wonderful. In the chat box, I cannot see any questions right now. So I now invite Dr. Gopal Sharma to give vote of thanks at the end.